Hello, and welcome back to Young Lung Cancer Initiative's Education Series with Dr. Negrao, and he's from MD Anderson, a thoracic oncologist, and he does research particularly around the KRAS mutation. In the first episode, we heard about just what is KRAS, how is that gene affecting the cancers. Today, in this conversation, we're going to kind of learn about what the KRAS standard of treatment is currently and how these cancers are managed in patients once they're diagnosed. So I'm going to turn it over to Dr. Negrao and let him get started.
Hi, Leah. Good morning, everyone. Glad to be here. So for the second part, I'm going to talk a little bit about how we currently treat patients, particularly with stage 4 KRAS mutant non-small cell lung cancer. So our current best strategy for this type of lung cancer population is really centered around immunotherapy. So you might have heard of some of these drugs. They're called PD-L1 inhibitors. That remains our backbone of treatment now for patients with KRAS mutant lung cancer. And then there's a couple of options about either combining this with chemotherapy or not. The typical chemotherapy drugs that we used are carboplatin and pemetrexed, which typically are drugs that, even though it's scary and concerning for a lot of patients when they hear the words chemotherapy, it is still, out of a lot of the regimens that are out there for treatment of cancer, for the most part, pretty well tolerated for most patients, even for patients that are in their more senior years. But the issue with these types of treatments is that the outcomes are largely determined by some key biomarkers, some key features that are present in KRAS mutant lung cancer that can kind of let us have a sense of how the patients are going to do with that type of treatment, right? So one of the examples that we have there is a marker called PD-L1. So that's a percentage number that goes from 0 to 100. And that tells you how likely it is for a patient to respond to treatment with a PD-1 or a PD-L1 inhibitor. So I think that that's an important point number one. Important point number two in terms of making these treatment decisions, and I typically use that a lot in my clinic, is how much disease the patient has and how symptomatic it is from that disease. Right. So typically patients that have larger tumors, more sites of spreading of the cancer, that have symptoms, that are struggling, for instance, with pain, cough, shortness of breath, those are typically patients that you prefer to use chemotherapy. And then one of the emerging options that we're currently seeing is that for a specific subgroup of patients, like the ones that we talked before, the ones that harbor STK11, KEAP1 mutations, there is a potential role for maybe integrating a second immunotherapy drug to their treatment regimen, which is called a CTLA-4 inhibitor. Two commercially available drugs from that class are ipilimumab and tremelimumab, and they seem to be particularly effective for patients that harbor these difficult to treat co-mutations within their lung cancer. So those would be the three key things that I keep track of and that I use for making treatment decisions and to decide on what our frontline treatment strategy should look like for patients with KRAS mutant lung cancer.
So it's more of like, some of the other mutations, if you have EGFR exon 19, you just go straight to this first line treatment, whereas you're saying you kind of have to look at each individual patient and their co-mutations to see what vein that they would best respond to, I guess.
Correct. So like I said, I think that the three, there are other things, but the three key things that I think patients need to be aware of that their doctors are going to use to make treatment decisions are those three factors that I just mentioned. It's PD-L1 expression, disease burden and patient symptoms, as well as a co-mutational background that can give you a good sense of what the overall clinical outcomes of those patients and how effective these therapies are going to be for treating their cancer.
I could see where that whole picture is necessary to make a decision on treatment.
But the challenge still remains that even with these novel, exciting therapies, we use these markers to really individualize treatment decisions for a given patient. So it's really like what we've always pictured personalized medicine would be. Unfortunately, for a lot of these patients, their cancer will be controlled for a limited period of time. So in general, especially for patients that are PD-L1 negative or that have a low PD-L1 expression, you're looking at time of cancer control that will hover around the 6 to 9 months range, which is very suboptimal for our patients. right? Um, so that's why we're starting to develop and starting to look at novel therapies that could potentially represent opportunities for this patient population. Focusing specifically on patients with KRAS G12C mutations, we currently have as salvage treatments. So when chemoimmunotherapy stops working or didn't work, there are two approved agents commercially that can be used to treat their cancer. One of them is called Adagrasib, and the other one is called Sotorasib. The respective brand names are Krazati and Lumakras. And these are drugs that represent a major breakthrough because KRAS has always been considered, quote unquote, the Death Star of lung cancer. It's a really tough protein for you to be able to inject a small molecule in there that's able to turn off that cancer oncogene. So the proof of concept and the registrational approval of these drugs represents a major breakthrough in terms of targeted therapies that extend beyond EGFR, ALK, ROS1, and now deeply moving into the KRAS space.
So, I think most people associate chemo with an infusion drug, probably immunotherapy as well. But when you're talking about these other two that you're starting to see emerge, are those infusion? Are they taken orally? Are the side effects worse or better?
These are oral therapies, both of them. So adagrasib is a pill that you take twice a day, and sotorasib is also a pill that you take once a day. Their clinical efficacy, Leah, looks fairly similar. You do see higher chances of shrinking down the cancer with adagrasib compared to sotorasib, but it's not that much difference. So one is in the high 30s, the other one is in the low 40s. And the time of cancer control between the two of them looks quite similar, hovering around the 5 to 6 month range. So as you can tell, definitely an improvement. But that's one of the challenges that we face right now, is that because KRAS is so heterogeneous, like we discussed before, there are some patients that are going to derive very significant clinical benefit and will have their cancer controlled beyond the year, some patients beyond a year and a half. There are patients that are on these drugs for more than 2 years at this point. But at the same time, there are patients that are going to have very early disease progression with these molecules, right? So it brings us back to that co-mutation side of things that we were discussing before. So our group led a multi-institutional effort across many centers in North America and in Europe, where we identified some key co-mutations together with our collaborators that are clearly associated with early disease progression to drugs such as sotorasib and adagrasib. So some of the examples that we talked about before include KEAP1, right? STK11 was also one that was enriched in patients with early progression. But two other key ones that were identified, which are not as prevalent as these two, are SMARCA4 and CDKN2A. So these seem to be very bad actors that are clearly associated with early progression and poor outcomes with these G12C inhibitors. And then we took that a step further. So this is an effort that I personally led in a collaboration with industry within our group, looking at these clinical outcomes in patients that were treated on the clinical trial that led to the approval of adagrasib. And we validated some of these co-mutations like KEAP1 and STK11, but we were also able to take this a step further and showed that even if you don't have a KEAP1 mutation or an STK11 mutation per se, the cellular effects that can come from poor function of these genes or decreased presence of these proteins in the cell, which is what we call a NRF2 signature. That signature now that extends beyond just mutations, that now takes you to like the gene expression, the way that the genes within the cells are being expressed. So that signature was also clearly associated with a very poor outcome to these G12C inhibitors. But if you're a half glass full kind of person, you can actually say, okay, but what if you don't have these bad actors? What happens then? And what we were able to identify is that if you don't have KEAP1, if you don't have STK11, if you don't have that NRF2 signature, which is a pretty substantial portion of patients, we're talking about 32% of patients, that population will have an 80% lower chance of progression with adagrasib and a 90% lower chance of passing away from your cancer when treated with adagrasib compared to patients that have these other poor genetic features in their cancer.
Okay, so it does make a difference for quite a few people to have this information.
And a very substantial difference for a lot of
Yeah.
these patients. So you can clearly start to see that there are some patients that will derive a lot of benefit from these drugs, but it's just that we got to get better in terms of identifying these patients.
The people that are taking it for 2 years, are those the people that you're saying are going to maybe be more successful on this drug for even longer than 2 years? Is that the hope, is that it would stretch out to be?
It's possible because as we're following up these patients on the trial, as these trials are maturing, we'll have a clearer sense of like, what is our long-term outlook? Now, do I think that these drugs by themselves are going to be as successful as, for instance, ROS1 inhibitors, ALK inhibitors, EGFR inhibitors? I think it's a little bit more challenging because it brings us back to that heterogeneity question of KRAS, right? Well, not question, aspect of it. So these are tumors that typically have more versatility in them. They're more adaptable. They're more evolutionary. They're able to find ways more easily around these treatments. So I don't think we're going to see, at least for these drugs, clear successes or the magnitude of successes that we've seen with some of these other oncogenes. But that's where research comes into play. And I know that we're going to be discussing this about second generation, third generation KRAS inhibitors that are more potent, more selective, and that can really represent a significant next step in terms of continuing to develop, in terms of drug development for these patients.
I do think this has been very educational. I mean, I'm learning a lot just listening. As a patient that doesn't have KRAS, you get so focused on what your mutation is that you don't always know what is going on with others. In closing this episode, because I know this might be something that other patients are thinking of, someone with ALK or EGFR, whatever, a different, not the KRAS mutation, can our cancer then turn into a KRAS-driven cancer as well?
So for EGFR, ALK, and ROS1, those are typically the cornerstones. They're their backbone of the cancer. So those markers are going to be present within your cancer indefinitely. It's very, very uncommon. You have like anecdotal cases where those markers disappeared, right?
Okay.
So transforming from one to the other is extremely uncommon. Okay? Now, what you can see though is some of these patients, because they're receiving such effective therapies, let's call that the cancer starts to do some creative thinking of how to bypass that. And then in those circumstances, it is possible for you to start acquiring additional mutations within the cancer. And one of these is KRAS.
Okay.
Not very common, but it can happen. And typically what you usually see is the KRAS G12D mutation emerging. And again,
Okay.
and this is the one that in our previous snippet we mentioned that was more present in never smokers. So that
Okay.
continues to hold up in this EGFR population. A second one that you can also see emerge in this population is called BRAF V600E. That one is a little bit 50-50. You have patients that are never smokers that develop that mutation, but you also see those present in current or former smokers. But that's another one that you can identify as well at progression to drugs like osimertinib.
Gotcha. We've learned some about that for sure. So, well, I want to thank you again for being here today. This is, like I said, been very informational and educational. For those of you that are listening, we are going to have another installment, and that's going to be kind of like what's on the cusp or what's coming down the pipeline for people with KRAS mutations. And I think that's where a lot of us get excited, because what we have now is great, but we're always looking to what's coming next, because we know that chances are we are going to have progression and need something better, different, newer down the line. So thank you so much for being here today. I really appreciate it, and I look forward to our next segment.
Thank you so much, Leah. I really appreciate the invitation.
No problem.